HighBridge, a division of Recorded Books, presents the Type 1 Diabetes Self-Care Manual, a complete guide to Type 1 diabetes across the lifespan for people with diabetes, parents, and caregivers. By Jamie Wood, M.D., and Ann Peters, M.D. Read by Laural Merlington. Chapter 1. The Basics of Type 1 Diabetes. Diabetes impacts millions of people around the world. Most have Type 2 diabetes, but an important minority have Type 1 diabetes. Type 1 diabetes has unique features and, contrary to popular belief, is not a disease only of children. It occurs at any age and in people of every race, shape, and size. In fact, there are more adults who have Type 1 diabetes than children. This book was written to discuss Type 1 diabetes in everyone, from infants to the elderly, from those who are newly diagnosed to those who have had it for many years. No matter what the age, however, it is important to realize that while diabetes isn't yet a curable disease, it is a very treatable disease, and no matter how frightening and frustrating it is, people with diabetes can live long, healthy, and happy lives. Our goal is to provide you with the tools and resources to help make that happen. Type 1 diabetes can be diagnosed at any age and in people of every race, shape, and size. What is diabetes? All books on diabetes start with a description of diabetes. It is often frustrating for people with Type 1 diabetes to be misperceived as someone with Type 2 diabetes. Although there are many similarities between Type 1 and Type 2 diabetes, the cause of each is very different, and generally the treatment is quite different. However, we are discovering more overlap between the types, especially for adults who are newly diagnosed, and this can be confusing. This will be discussed in more detail later and in Chapter 2. Age alone does not define what type of diabetes you have. The feature that unites all types of diabetes is too much glucose in the blood. We all need glucose, a type of sugar, to fuel our brain, heart, and muscles. Glucose is found inside cells, where it is changed into energy as needed, as well as in the bloodstream, where it is carried around to all of our organs. Blood glucose either comes from the food we eat or is made by the liver. Our bodies have a wonderful and complicated system for making sure that blood glucose levels are normal day in and day out. Normal blood glucose levels are usually around 100 milligrams per deciliter. Before eating, normal blood glucose levels are 700 to 100 milligrams per deciliter, while after eating, the blood glucose levels never go above 140 milligrams per deciliter. If our glucose levels were to fall too low, we would lose the ability to think and function normally. If they were to go too high, it could cause damage to the body that happens over the course of many years. Patients are diagnosed as having diabetes if their blood glucose is greater than or equal to 126 milligrams per deciliter when fasting. Their blood glucose is greater than or equal to 200 milligrams per deciliter, and they have symptoms of diabetes, and or their A1C result is greater than or equal to 6.5%. An oral glucose tolerance test is rarely used to diagnose people with diabetes, and if the blood glucose level is greater than or equal to 200 milligrams per deciliter 2 hours after drinking a sugary sweet drink, the diagnosis of diabetes may be made. In most cases, except in those who are very sick, any test should be repeated to confirm the diagnosis. Criteria for the diagnosis of diabetes. Fasting plasma glucose greater than or equal to 126 milligrams per deciliter. Fasting is defined as no caloric intake for greater than or equal to 8 hours. In the absence of unequivocal hyperglycemia, results should be confirmed by repeat testing. Or 2-hour plasma glucose greater than or equal to 200 milligrams per deciliter during an oral glucose tolerance test, or A1C greater than or equal to 6.5%. Or, in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose greater than or equal to 200 milligrams per deciliter. Normal blood glucose level is usually around 100 milligrams per deciliter. People with diabetes check their blood glucose levels by poking their fingertips or using continuous glucose monitoring, so they know how close their blood glucose levels are to normal. In addition to checking the blood glucose level directly, there is a way to track blood glucose levels over time, known as the A1C. An A1C result gives the doctor and patient an idea of a person's average blood glucose levels over the prior 3 months. It does not replace daily blood glucose monitoring, but in combination with daily readings, an A1C can determine how well the current diabetes treatment plan is working. A normal A1C level is 4 to 5.7%. Most people with diabetes should aim for an A1C of less than 7.5% in a child or less than 7.0% in an adult who is not pregnant, although patients should have their own goals for what their A1C should be based on their own individual circumstances. For example, a healthcare provider might suggest a goal of less than 6.5% for a person who can reach this without frequent or severe hypoglycemia. A person who is elderly and troubled by hypoglycemia may have a goal of an A1C less than 8%. To better understand diabetes, it helps to know how your body uses glucose. Your body breaks down the food you eat into glucose. What's glucose? A form of sugar in the blood. Your bloodstream carries the glucose to cells throughout your body and uses it for energy. To help glucose get into your cells, beta cells in your pancreas make insulin, which attaches to each cell and opens the door for glucose to enter. Once glucose is inside your cells, your body can use it for energy. When your body can't make enough insulin, type 1 diabetes, or when not enough insulin is made and the body resists the action of the insulin, type 2 diabetes, the levels of glucose in the blood rise. Insulin is made in the beta cells, which are part of the islets of Langerhans in the pancreas. These islets also have alpha cells, which make glucagon, as well as delta cells. Normally, glucagon protects us by promoting production of glucose from the liver, helping to prevent a decline of glucose in the blood that otherwise would occur during fasting. But in diabetes, glucagon may fight or resist the action of insulin at inappropriate times, when glucose utilization is required. In the beta cells, insulin is created first as a big molecule called proinsulin. Proinsulin is broken into 2 pieces, insulin plus C-peptide. C-peptide is important because it can be used to measure how much insulin a person is making, especially if someone is on insulin shots. We don't think that C-peptide does anything itself, but the more C-peptide a person has, the more insulin they are making. Type 1 diabetes. Type 1 diabetes begins with the immune system. The immune system has a very tough job. Evaluate every cell, protein, and molecule in the body and decide whether it should stay or go. Immune system cells constantly patrol the body for trouble. Bacteria, viruses, fungi, and even cancer cells. If these enemies of health are discovered, the immune system mounts an attack. Sometimes, however, the immune system can get it wrong and see danger where there is none. When that happens, an autoimmune disease, such as rheumatoid arthritis, celiac disease, or type 1 diabetes, may be the unfortunate outcome. In type 1 diabetes, the immune system mistakenly kills the only insulin-producing cells in the body. In type 1 diabetes, the immune system mistakenly believes that certain parts of the pancreas, the beta cells, need to be killed. The main job of the beta cells is to sense rising glucose levels in the blood and respond by releasing insulin. In fact, beta cells are the only cells in the body that can make insulin. So, when the immune system attacks the beta cells, it destroys the body's sole insulin factory, leading blood glucose to rise unchecked. And that is type 1 diabetes. What does new-onset type 1 diabetes look like in an infant or child? The young child who is urinating frequently, drinking large quantities, losing weight, and becoming increasingly tired and ill is the classic picture of a child with new-onset type 1 diabetes. A child who is potty-trained and dry at night, who starts having accidents and wetting the bed again, could have diabetes. Although it is easy to diagnose diabetes in a child by checking blood glucose levels at the doctor's office or emergency room, sometimes the tricky part is recognizing the symptoms and raising the awareness that young children, including infants, can get type 1 diabetes. Sometimes children can have diabetic ketoacidosis, DKA, when they are diagnosed with diabetes. DKA is a condition in which high levels of acid, in the form of ketones, substances that are made when the body breaks down fat for energy, build up in the blood because of a lack of insulin in the body. DKA is a medical emergency that usually requires hospitalization and immediate care with insulin and intravenous fluids. These children are immediately started on insulin therapy, which they must remain on for the rest of their lives. They may go through a phase, early in treatment, during which insulin requirements seem to fall, commonly called the honeymoon phase, but over time, all require appropriate doses of insulin to keep their blood glucose levels in the normal range. A math problem. Being diagnosed with type 1 diabetes at age 13 was a whirlwind. I remember the symptoms of being tired and thirsty all the time, of going to the doctor and giving a urine sample, of waking up in the ER with 2 IVs in me. But I can't remember anyone telling me, "You have type 1 diabetes." I don't think it happened, and no one ever explained what having type 1 diabetes was. I was told I needed to test my blood sugar and inject insulin before I knew what either of those meant. Because of this, type 1 diabetes didn't really feel like it was something I had. It was more like a math problem I needed to solve a few times every day than a physical thing happening to my body. To this day, I still find it weird to say, "I have diabetes," since I don't feel like I have it. Sure, I feel the symptoms when my blood sugar is out of range, but I don't feel like anything has changed. That's the biggest lesson I've learned about having type 1 diabetes. Yes, you no longer produce insulin, but you haven't changed. You are still you. You'll have your highs and lows, physical and mental, but that's no different than anyone else with or without type 1 diabetes. Type 1 diabetes does not define you. Craig Stubing, 29, is a documentary filmmaker and creator of the Beta Cell podcast. 10 French fries. The first doctor was wrong. I didn't have mono, a disease that would last a few weeks. I had type 1 diabetes, a disease that would last my lifetime. The doctor tried to explain to me how things would work now that I was a type 1 diabetic officially. She said to an 80-pound 15-year-old, "Everything will pretty much be the same. Like, you can still eat French fries. You just have to count how many you eat, and you can't eat more than 10 fries, and you have to take medicine via syringe before you eat them. No, I thought, that's not the same. I remember the only thing that actually made me feel better. My mom said, "It's like taking medicine 3 times a day. You know how Mommy takes thyroid medicine every day. Very different circumstances, but she tried, and that made me feel better." Amira Meghani, 35, is an attorney and mother of 2. What does new-onset type 1 diabetes look like in an adult? When adults are diagnosed with diabetes, they are often told that they have type 2 diabetes at first. This is often due to a lack of an understanding in the medical community that type 1 diabetes can start at any age. It seems more likely that a young adult, someone in their late teens or early 20s, may be diagnosed appropriately with type 1 diabetes, but anyone can be misdiagnosed. Adults with new-onset type 1 diabetes are often not sick at first. Their doctor finds an elevated blood glucose level at a routine visit and starts them on a diet, exercise, and an oral medication. If you or someone you know is diagnosed with type 2 diabetes but isn't responding well to the typical treatments for type 2 diabetes, it may be worth a visit to an endocrinologist to determine what type of diabetes you have. Generally, this requires antibody tests and possibly the measurement of a C-peptide level. The testing suggested is discussed in Chapter 2. 10 months of hell. I was 50, having pre-surgery tests, and the surgeon said my blood sugar was way too high. He did the surgery anyway, and then referred me to my primary care physician, who tested my blood sugar again. It was still very high, so he said he could treat me for diabetes. Type 1 never came up in the conversation. He sent me to an endocrinologist in his practice. She was a horrible person and an inadequate endocrinologist. She treated me for type 2 diabetes, with no success. I could barely manage my blood sugars. I'd have to exercise any time I wanted to eat. I'd go over to someone's house for dinner, and I'd have to go on their treadmill before I could even sit down at the table with people. Otherwise, my blood sugar was just going to go shooting up. I hated the endocrinologist anyway, because she was so mean. Finally, I found another endocrinologist recommended by someone, and he also treated me for type 2, with no success. They were all trying different medications, none of which worked. Then I switched to another endocrinologist who had type 1, and he also treated me for type 2. I tried to persuade each doctor that I wasn't type 2, but they would all say, "Well, let's just try one more medication." Finally, I found an endocrinologist who understood that I didn't have type 2. Meanwhile, 10 months of hell had passed. It was so frustrating. So much of my time and energy was devoted to keeping my blood sugar under control. For that whole year, I never ate dessert once. Anybody who knows me knows that was a horrible sacrifice, because chocolate is one of my favorite foods. Anyway, that endocrinologist started me on insulin, and my life became much easier. Cynthia Goldstein, 68, is an administrator at the Department of Veterans Affairs. What is type 1 diabetes like in the person who has had it for many years? People who have had type 1 diabetes for a long time have learned to live with it in one way or another. Some people who have had diabetes for greater than or equal to 40 years started out testing their urine for glucose and giving themselves only 1 or 2 shots of animal insulin per day. We were not very good at managing it back then. Today, newer insulins and technology can make a world of difference in terms of managing blood glucose levels, but for people used to surviving without these tools, change can be intimidating. Also, Many people who have had diabetes for a long time don't like to count their carbohydrates. For many, they have had the disease for so long that they guesstimate how many carbs they are eating and adjust their insulin dose by instinct more than numbers. This isn't the wrong thing to do. If it works, why change it? However, it is a good idea to meet with a diabetes educator and/or a registered dietitian every year or two, just to stay updated on what is happening in the world of diabetes and to gain new and helpful information. You might want to switch diabetes doctors if things aren't working out, but this might be hard to do given restrictions of insurance plans and geography. Still, seeking a second opinion or finding a way to treat your diabetes better can be worth it if the care you are getting doesn't seem to be working. Sometimes the primary care team is a good place to start when seeking further referral to a new diabetes doctor. Also, diabetes educators usually know who is good. Through the years, I was 15 when I noticed the excessive thirst of the onset, and it took a few days for me to mention it to my parents. I recall being stunned by the news, but I also recall thinking of it as being an obligation for which I would be responsible. At that time, tools and treatment were limited by today's standards. The only insulins available were animal-derived regular and NPH. Home glucose testing did not exist. Lab testing for A1C was not even proposed until 1976. All we had then was urine test strips. I was fortunate that my father was a physician and a diabetic, and my mother a nurse, so there was a lot of support and understanding. Age 15 to 20, 1956 to 1961, I did the best I could without decent testing equipment or single-use disposable needles, and had a fairly normal childhood and college, including hiking, camping, and cave exploring. Diabetes was always there, but I tried to live life as though it were not. Age 21 to 27, 1962 to 1968. This period of my life was spent as a musician, touring the U.S. and Canada. I still relied on my parents for diabetic supplies, insulin and urine test strips, and for glass syringes and needles, which I kept in a small mason jar filled with alcohol. There were not many hypoglycemic reactions that I recall, probably because my glucose level was much higher than I would tolerate now. This was partially because of my youth, but also there was no method to test for blood sugar levels in the mid-1960s. Age 28 to 39, 1969 to 1980, I finally started to grow up and pay attention to my future, working straight jobs and completing law school. Control was still tenuous, looking back, but I continued to live my life in spite of it. Age 40 plus, post-1981. This era brought major changes to my life with diabetes. First, I realized that I had to be serious about control when I first noticed retinopathy and had a series of successful laser photocoagulation treatments over 6 years. Second, home glucose monitoring devices became available. First, test strips, then meters, and finally continuous glucose monitors that are capable of measuring the rate of change in addition to glucose levels. Third, better injection technology, such as a jet injector and fine-gauge disposable needles made traveling in everyday life easier. Fourth, insulins continued and continue to improve. Adam Cochran, 76, is Associate General Counsel at a major academic institution and an avid water skier. All the things I teach my children because I have type 1 diabetes. 1. It has nothing to do with anything and everything to do with everything. 2. It's not an excuse for anything. I can do anything, except the things I can't do because I'm not 20 anymore, like a cartwheel. But when I was 31, I did run the Los Angeles Marathon, I've had 2 healthy pregnancies. I love my job. I succeed and fail, and I get overwhelmed just like all women do. 3. Having said that, my children know not to distract me in the morning when I take my insulin. Otherwise, I might not remember later that I took my insulin, and then I might take it accidentally twice. That was a sucky day, and I couldn't drink enough juice to catch up. 4. Quinoa really does taste good with Parmesan on it instead of pasta. 5. Thinking cereal is a healthy breakfast is a scam. 6. You really do use math when you grow up. 7. Exercise really is the best medicine. It treats everything. 8. Health insurance is a good perk of employment. 9. Be nice to the smart kids at school. They might cure diabetes when they grow up. 10. Whatever life throws your way, we can deal with it together. Leslie Craft, 47, is a physical therapist and mother of 2. Chapter 2. Autoantibodies. How Type 1 Diabetes Begins. Thanks to advancements in diabetes care, such as type blood glucose management, people with type 1 are living longer than ever. The flip side of that story is that there are now more people with type 1 today than ever before. It's estimated that 5 to 10% of Americans with diabetes have type 1, which translates into around 1 to 2 million people. While most people with diabetes have type 2, type 1 is the predominant form of the disease in youth. Though there is a rising number of children and adolescents with type 2 diabetes, almost all children aged less than 10 years with diabetes have type 1, and most teenagers as well. In the U.S., 18,400 children and adolescents are diagnosed with type 1 each year, compared with 5,100 cases of type 2. Worldwide, 78,000 people are diagnosed with type 1 diabetes each year, though there are huge differences between countries. For example, Finland and Sweden have the highest rates of new cases of type 1 diabetes in the world, while China and Japan have among the lowest. There may be valuable information in those differences. Scientists are studying how genes, lifestyle, diet, and environment, factors that may differ between nations, affect the risk of developing type 1 diabetes. Who and why? While the details remain fuzzy, both nature and nurture have a hand in whether a person develops type 1 diabetes. Type 1 diabetes stems from interactions between genes, the environment, nature, and the immune system. Family genes. Long ago, researchers recognized that type 1 diabetes tends to run in families. Overall, approximately 0.3% of the population has type 1 diabetes. Roughly speaking, there is a 4% chance that a child of a woman with type 1 diabetes will get type 1 diabetes, and a 6% chance that the child of a man with diabetes will get it. From the positive perspective, approximately 95% of all children from a person with type 1 diabetes will not get the disease. However, the increased risk of type 1 diabetes in families means genes play a role. Approximately 95% of all children from a person with type 1 diabetes will not get the disease. By comparing the genes of people with type 1 diabetes to those in the general population, researchers have identified a series of genes associated with type 1 diabetes. The strongest genetic influence appears to come from a specific part of chromosome 6, known as the human leukocyte antigen, HLA, region. The HLA genes are blueprints for building molecules that decorate the surfaces of cells and help regulate the immune system. That makes sense, as type 1 diabetes involves immune system dysfunction. The roots of that dysfunction may be...
Sample complete. Ready to continue?